Afternoon. My name is Sepsis Alliance. I am a third-year internal medicine resident at Moses Cohen Hospital in Greensboro, North Carolina. Today, I will be talking about my quality improvement project that focused on sepsis bundle compliance at my hospital and the impact of SeptiCyte RAPID. As we all know from the most recent Surviving Sepsis campaign guidelines for the management of sepsis and septic shock, specifically related to antibiotic timing, the recommendations are to go ahead and administer antibiotics within 1 hour of sepsis recognition and with as a delay of up to 3 hours, depending on your suspicion for sepsis. This can further be divided into varying levels of probability of sepsis based off of clinical decision making based off the clinical presentation of the patient, as well as other factors, including their laboratory findings, if there's any lactic acidosis or any procalcitonin. In patients that we have a low sepsis probability, the recommendation is to closely monitor the patient. We can hold off on antibiotics. In patients that are suspected to have sepsis with an intermediate probability, if depending on with shock or without shock, in patients without shock, you would like to assess for infectious versus non-infectious etiologies. And if there's a concern for infection, recommendations to go ahead and start antimicrobials within 3 hours. However, if a patient develops septic shock or has a very high probability of sepsis, the recommendation goes to administering antibiotics immediately, ideally within an hour recognition. As I said previously, there was, the diagnosis of sepsis can be quite challenging and often relies on, multiple different aspects, including white count, fevers, and in patients suspected of shock, you always also can look at lactic acidosis and procalcitonin as well. However, none of these measures have been very, very great at indicating sepsis. Until I recently stumbled upon this SeptiCyte RAPID assay, which was recently approved by the FDA as a assay to help differentiate SIRS presentation versus sepsis. This is a gene expression assay measuring the ratio of mRNA of 2 host response genes, reported as a clinical risk score from 0 to 15, as we can see in this slide with these ranges here. It's given as a likelihood of sepsis and with interpretation given into 4 discrete bands. As we can see on the next slide when I go there, I was most impressed that they give you actionable results within approximately 60 minutes. And it's independent of disease severity or causative pathogens, has been studied in the critically ill ICU patients, COVID patients, patients that have been immunocompromised, and even pediatric patients. A little bit more about the SeptiCyte RAPID assay in itself and helping to differentiate sepsis versus SIRS. As I had talked about earlier, low probability of sepsis would be on this 0 aspect, with the highest probability of 15 with a score of 15 in the band 4. It is very sensitive in detecting sepsis, especially low risk, with a sensitivity of 0.94 and very high likelihood ratio of 5.86, and the high risks of sepsis with specificity of 0.9. The probability of sepsis, as you can see in this graph, increases with the increasing in band, up to 81%. And there has been a very good differentiation between SIRS, as you can see here, and sepsis in patients presenting with SIRS criteria. This actually graph helps look at a little bit more about the SeptiCyte RAPID score in comparison to lactic acid alone, procalcitonin, and then septic score. As you can see here, the septic score has a very high performance when compared to procalcitonin and lactic acid in diagnosis of sepsis patients. So on to looking specifically at my quality improvement study. So my study specifically looked at the compliance of surviving sepsis campaign, antimicrobial initiation, and correlation of the septic score or the sepsis Untiexpress assay score in patients with suspected sepsis. This was a retrospective study, non-interventional evaluation of hospitalized patients with suspected or documented sepsis that presented to the emergency department at Cone Health. Primary objective of the study was to evaluate the consistency with the 2021 surviving sepsis campaigns as far as antibiotic timing recommendations went, based on the low, intermediate, or high probability of sepsis, and also to evaluate the possible impact of including the septic score on sepsis probability determination. This study looked at all adult patients that presented to the Cone Emergency Department with a code sepsis alert within a certain time frame. I personally collected demographics and sepsis indicators, looked at the clinical probability of sepsis with Dr. Hassan specifically, and documented first antimicrobial doses. I also ordered the SeptiCyte RAPID assay to be collected within that 6-hour window of initial presentation, as it was collected with other lab blood tests. There wasn't any additional specific patient interventions necessarily because the SeptiCyte RAPID assay scores were only available to me in the study and not to the clinician taking care of the patient. The evaluation was based off of the first dose of antibiotics with sepsis probability and bundle completion rate. So this looked at the study ranged from June throughout the end of October, looking at a total of 102 patients, had a pretty even distribution between males and females, with a standard age of about 62. You can see here that there were approximately 15 deaths in the patients that did have SeptiCyte ordered, but those were also a larger cohort than those without. Result-wise here, you can see that the SeptiCyte score did line up pretty well with the patients that did not have any concerns for sepsis and patients that were very high clinical suspicion for sepsis. As you can see here, once again, the patients with low SeptiCyte scores did correlate with patients that had a lower sepsis probability, and same here with patients with high probability of sepsis. It did also help discriminate a little bit between possible and probable sepsis patients, and it allowed for us to further evaluate these patients in 48 to 72 hours for continued antibiotics needs. This specifically looked at the antibiotic administration within 1 hour of patient presentation, as you can see in band 1, and all the way through, band 4, which indicated high probability of sepsis. There was the antibiotics within 1 hour recommendation was not met. Specifically in band 1, obviously you don't need that antibiotics within 1 hour. However, my main concern was with the patients with a very high probability of sepsis or septic shock. The recommendations for antibiotics within that 1 hour period were not met in the majority of these patients. This is very similar with the patients with probable sepsis and even with patients with suspected of possible sepsis. So, and these all, as you can see here, these all range for band 1 all the way through band 4, with the highest number of deaths being in this group. This is, the 3-hour bundle compliance. Once again, similar findings as the antibiotics, with most concerning being the patients with definite sepsis not meeting the 3-hour bundle compliance, and similarly with the probable sepsis as well. Once again, looking at the clinical assessment and SeptiCyte results in patients that were diagnosis of SIRS or low likelihood for sepsis, as you can see, the average SeptiCyte score here was about 4.4, with a bundle compliance of only about 14%. Once again, in these patients, the antibiotics or the bundle are not required, but just as a comparison. In patients with possible sepsis, you can see here the SeptiCyte score did go up with the average SeptiCyte score of 6.2. However, the bundle compliance was only about 56%, as you can see here with the red indicating areas for improvement. Similarly, in patients with probable sepsis, once again, you can see that the average SeptiCyte score was about 6.7. Here, bundle compliance was only 57%, with a lot of these patients not meeting the antibiotics within less than an hour mark. This is the most concerning to me specifically with the patients that were thought to have definite sepsis. The average SeptiCyte score did align with that, with a higher average SeptiCyte score of 8.9. However, bundle compliance was only 62%, with a majority of the antibiotics not being given in the less than 1 hour period, as you can see with all the red. So just in summary, the patients that were classified as not septic, as you can see here, they ranged mostly in band 1 and band 2 with a low risk of sepsis. The patients that were classified as definite sepsis, they mostly ranged in bands 3 and bands 4 without confirming the high probability of sepsis. And then in patients that were classified as clinically as possible sepsis, a lot of those ranged in the band 1 and 2 category with a low probability of sepsis, versus probable sepsis ranged mostly in bands 3 and 4 with an increased probability of sepsis here. So for me personally, the most concerning is this patients that correlated with a high probability of sepsis and were confirmed with SeptiCyte band 4 scores. That does give us a very high opportunity for process improvement for early antibiotic administration and bundle compliance to help improve these outcomes with highest mortality rate. In SeptiCyte band 1 patients, in which patient, their presentation was consistent more so with SIRS than sepsis, it indicates to look for other etiologies such as possible, post-seizure, post-ictal states, or PE. For patients in band 2 and band 3, once again, it helps to reassess. It indicates to clinician to reassess other etiologies for patient's presentation, and also to help reevaluate in 48 to 72 hours if there is even a need to continue antibiotics at that point. Next steps at my hospital that I would like to do is obviously incorporate the SeptiCyte RAPID into initial sepsis bundle workup, especially with it correlating so well with the clinical assessment. And then also to help guide these processes to make sure that we are improving antibiotics within 1 hour to improve our bundle compliance for patients within the high probability of sepsis. And patients with probable or with higher probability of sepsis, making sure that even determining the optimal antibiotics and bundle timing while we're evaluating with a low possible probability. I'd like to specifically thank Dr. Alva, Dr. Hassan, Jane, and Dr. Roy for helping me with this study. And if there are any questions at all, I'd be more than happy to answer at this point. Any further questions, you can reach me personally at my email, or if you want any further information about the SeptiCyte RAPID, you can visit our website or contact Jane directly.